Thank you, Dr. Ravi. As you have accepted that you have a low-grade lymphoma, I had hepatocellular carcinoma about 12 years back. I am immunocompromised. I am having Ayurvedic treatment and also immunosuppressant injections. I am fine now. I am not going to the hospital. I am at home. Should I take vaccine or booster or leave it as it is? My health is fine now.
Yeah. I'll ask you a couple of questions if you don't mind. Did you get
Yes,
COVID? Did you get COVID?
yes, yes, yes.
You
I
got
had
COVID. When did you get COVID?
after my 2 doses of 3 doses. After my 3 doses, I had COVID. To be frank, as you said, I did not bother to go and find out whether COVID positive or not. But all the symptoms and other things were severe. Pain was severe, and loss of taste, loss of smell. It was there.
So you have hybrid immunity because you had vaccine-induced immunity and you also had natural infection. So your immune system is still working. Okay. But
Thank you.
the call you have to take is what is the degree of your immunosuppression? If you are severely immunosuppressed, then maybe you should consider taking a booster dose. And the booster dose, none of the Indian vaccines are updated vaccines. What is updated vaccine? I told you, they don't cover Omicron mutations. Whereas the Pfizer and the Moderna, which is not available in India, are the ones that give you updated immunity. There is no harm in taking booster because the vaccines that are available in India are safe. They do give protection for definitely 6 months to 1 year. The question then you will ask me is, every year do I have to take a vaccine? That's something that you have to take a call. Whether you take COVID vaccine or not, let me on this forum make a very sincere appeal. Please take influenza vaccine. If you get flu at this age, it generally is very risky. You will land up with severe pneumonia and you can go on to ARDS. The elderly are highly prone for severe disease. This year, actually, in India, surveillance data showed that COVID and influenza were running parallelly between February and up to now. Now the weather has changed, so transmissions have come down because it's summer, as Dr. Badri was telling. It's so hot. This weather does not favor transmission. So definitely influenza vaccine, I will stick my neck out and say, please take. COVID vaccine is something that you will have to take a decision. Maybe if you are consulting a physician, you can take his advice also. That's my honest answer.
Thank you, Dr. Ravi. Thank you very much. I am 81 now.
Very good.
Dr. Ravi, what about Paxlovid? If you do get a COVID infection, say you're fully vaccinated and you're not immunocompromised, but if you get COVID, do you recommend?
It is highly recommended now. That's one of the drugs that brings down virus replication in the respiratory tract, especially upper respiratory tract. But remember, Paxlovid is most effective when taken within the first 5 days, especially in the first 3 days. It completely knocks out the virus and thereby you get relief immediately, although it does have some side effects. So
and there is some rebound also, right? There is some rebound. Sometimes after you stop the Paxlovid, you become positive again.
Can you tell us a little bit more about it? This is something which is new to me.
Paxlovid is a drug, is one of the most effective antiviral drugs available for SARS-CoV-2, probably the best one that has ever been produced. It is available in India also now. So the moment you have symptoms of COVID, if you can get an RT-PCR done, and if it is positive, if it is within the first 3 or 4 days, the course is 5 days, and you do what it does is it knocks out the virus when it's in the upper respiratory tract. Remember, COVID disease is not because of the virus. It is because of the aggressive immune reaction the body produces. When the virus goes down into the bronchus and into the alveoli, it triggers an aggressive immune response, leads to outpouring of immune cells, a lot of inflammatory fluid, and that is what produces the ground glass opacities, and the oxygen transfer does not occur. That's where people have severe disease and even mortalities because of that. The idea is to keep the virus, prevent the virus from going down. And how do you do that? When it's multiplying actively in the upper respiratory tract, you give a drug that kills the virus, and the only drug that is very effective for that is Paxlovid. Just like Tamiflu is for influenza. Tamiflu, remember, when swine flu came in 2009, it did not have a great impact as COVID did because Tamiflu was available. And Tamiflu was a wonder drug. It really cleared the infection in a matter of 24 to 48 hours. In 24 hours, people started feeling better, and it prevented the virus from going down. In both flu and coronaviruses, for that matter, most of the respiratory viruses, they produce severe disease and death not because they destroy the lung epithelium, and it's not physical damage by virus. It is the aberrant host immune response that air sacs become flooded with inflammatory fluid, and therefore oxygen does not transfer.
Okay, thank you.
Professor Ravi,
Yes.
question from Chandrika Badrinath. Is COVID man-made?
Well, this is a debatable issue.
Obvious.
The WHO is very diplomatic in taking the stand. What are the arguments to say it is man-made? The arguments to say it is man-made is SARS-CoV-2, not SARS-CoV-1. The only coronavirus has a furin cleavage site, which is not present in any other coronavirus. Now, this furin cleavage site gave it the advantage of quick spread and adaptability to human epithelial cells. How did it acquire this furin cleavage site? There were scientists who were working on viral gain of function studies, both in the US and in China. So the proponents of the man-made theory say that it was an experiment that went haywire, but we can't prove it. The second possibility is there was a leak. There was a lapse in security in the Wuhan P4 laboratory. Probably the virus escaped or infected somebody, or it was discharged into sewage. So many other, once you don't have evidence, you can give 101 Alfred Hitchcock theories on how it came into the community. The proponents of the natural theory have some evidence to say that it is naturally, this occurred in nature, because bats collected in Thailand, in Vietnam, in Japan, and some parts of China in 2015, much before COVID became a problem or it was recognized, the bat viruses had this furin cleavage site. And they say it is a spillover that occurred in the wet markets of Wuhan. So the jury is not out yet. I like to believe that human beings are, I'm a very positive person. I think it's a natural spillover. But the lesson for natural spillover is to have very robust surveillance at places where spillover can occur. This is a lesson for us. And the lesson for man-made thing is you have to have biosecurity in all the labs that are manipulating viruses. And I think it's time to put those security measures in those places. I look at only the lessons. But even now, a group of us have advised the Indian Council of Medical Research to start One Health surveillance. What is One Health? Health that affects animals, birds, and environmental causes and human beings. All of it put together is One Health. So you need to do surveillance for One Health. Where do you do it? In places, natural places where man, animal, bird interaction is very close. If you ask me natural habitats in India, I will say it is the Northeast, because there are bat caves and people eat bats, and also in the Western Ghats, especially in places like Kerala, where there's a lot of domesticated birds in the ponds and there are bats. So spillovers can occur in these natural settings. Spillovers will certainly occur in wet markets of Southeast Asia, or it can occur in the jungles of South America or in the jungles of Africa. These are the hotspots where one has to be on the lookout, not only for SARS-CoV virus, there's more dangerous viruses like hemorrhagic viruses, like the Ebolas and the Marburgs and the Congo Crimean hemorrhagic fever and the likes of it. So the biggest lesson that we have taken, I take out as a virologist, is you should set up One Health aggressive surveillance in places, in the geographic locations in the world where spillovers have occurred.
Thank you. We all know that the coronavirus, when it started initially, was responsible for causing or involving any system in the body, causing all kinds of complications. Now that the virus is under control, and you say if you get infected, it's only a minor infection, can this minor infection cause similar problems affecting the other systems in the body?
The data is still emerging, Dr. Badrinath. We are talking of what is known as long COVID. What is long COVID? Well, 3 to 6 months after recovered from COVID, you start still manifesting some symptoms or new things emerge. Classic example, SARS-CoV-2 induced diabetes. There is now very clear-cut evidence that SARS-CoV-2 infects islet cells of Langerhans, and a small proportion of people, especially youngsters who had severe COVID, they become diabetic. Cardiac disease. The risk for cardiac disease has been higher in those who have had severe disease. That is because vascular endothelium is very rich in ACE2 receptors. Virus attaches there, damages the endothelial cells, that leads to microclot formation, and that's a risk for cardiac disease and stroke. So what we do not know is who is at more risk, whether it is Dr. Badrinath or Ravi or Sudhakar, that we have not understood. But the fact is that you know COVID, you know medicine. Like in your days and my days, if you knew syphilis, you knew medicine. In the 90s, if you knew HIV, you knew medicine, because these are diseases where manifestations were seen from head to toe. Every system was impacted. So long COVID, there's a lot of people who have set up registries and are doing follow-ups. Data is still emerging. How long this will last, we do not know. But one thing we know with long COVID is those who recovered from severe disease have a greater risk of getting long COVID than those who have had milder disease. Now, that kind of data has kind of clearly emerged.
Okay, thank you.
Hi, sir, Ravi. I have a couple of questions. My original understanding was that as the virus produces more variants, it becomes progressively weaker, the original virus. The other understanding I had was more recently, I had a rumor that the mRNA type of antibodies that were present in the vaccines that we took causes your immune system not to respond well to other viruses, including flu virus.
Well, let me answer from what I know and the literature that I have read. Regarding the first question, this is a myth. There's a general myth that viruses, as they go on mutating, they will become less, within quotes, virulent. That is absolutely virologically not correct. You take the current Omicron virus and put it into a human being who is a person who does not believe in taking vaccines. You will produce the same clinical phenotype what SARS-CoV-2 produced in 2020 or 2021. It is just that our immune system has seen SARS-CoV either through vaccination or through natural infection. So these new variants that are emerging, we are able to handle them better. Although, remember, they have a better fit. In fact, their fit for the receptors are much, much better than the parent virus. So if you take an immunologically naive person and put Omicron, you will get exactly this phenotype that you got in, let us say, 3 years back, that 60% will have mild infection, 30% will have moderate infection, 5% severe infection, and 3 to 4% will die. That is true for any immunologically naive person. So this is a myth that as virus acquires mutations, it becomes less virulent is a myth. It is not so. It is just that by the time these new variants emerge, all of us have either seen the virus through a vaccine or through natural infection. So we are able to handle it better. Now, your second question was whether mRNA vaccines blunt immune response to other viruses. This is again people, anti-vaccine lobbies who've been talking about it. mRNA vaccines are very potent vaccines. They do have side effects, we know that, but that it will have because we're learning about mRNA vaccines. Remember, for the first time in COVID, we used them, and there were cardiac myocarditis and others reported in a small percentage of people. So they do have their side effects, but it's not true that they blunt the immune response to other viruses. No. In fact, I must answer Dr. Murali's question. We had a chat before we started. mRNA vaccines have opened tremendous opportunities for developing vaccines for both other viruses and non-communicable diseases as well. If you look at the potential applications of mRNA vaccine that people are researching right now on, it encompasses other SARS viruses, influenza, hepatitis, HIV, leptospirosis, malaria, and also cancers. Dr. Murali was alluding to a very recent paper in NEJM where mRNA vaccines have been developed for pancreatic cancer. It's a very, very small study. And the data is that those people who received the mRNA vaccine for pancreatic cancer, they started showing signs of regression of the cancer and they're doing better. So I think This is a new toy and a new tool we have. We should titrate it and use it responsibly, and I'm sure it will make a big impact. The greatest advantage of mRNA vaccines is it is completely synthetic. You can create the vaccine on machines. You can synthesize the RNA if you predict the epitope and get the vaccine ready very fast, and you can do clinical trials very fast, so that you obviate the need for 10 years of research for an mRNA vaccine. For a conventional vaccine, here it will be much faster.
I have one more last question. This is the somewhat political, maybe. Going back to the beginning of 2020, I understood that Taiwan applied to become a member of the WHO and was quickly suppressed by the leader. Do you have any say on that?
No, I have absolute. In fact, I'm hearing for the first time this news. I must confess I'm not aware of this news at all.
We heard it only in the US then.
Badri, can I raise a question, Badri?
Yeah, please do. Yeah.
Professor Ravi, point blank presentation. Good. I heard you earlier. This is about the drug you mentioned, comparing
Paxlovid.
Tamiflu.
Tamiflu is
Hear
for
me,
influenza.
Dr. Ravi?
Yeah. Yes, sir.
This in comparison with Tamiflu, Olmesavir, you mentioned a drug which I didn't catch it. I lost touch with the net. And you said it's available in India now, which you suggested to start as soon as you think of Omicron, if I'm right,
Okay.
and even without RT-PCR, because as you said, sometimes RT-PCR takes time to show the positivity.
Okay.
Can I know the name of the drug and where is it available, please?
Paxlovid. Praxlovid. Paxlovid.
Paxlovid. Okay. What is the drug, Professor Ravi?
It is a drug that prevents replication of SARS-CoV-2.
Oh,
It acts on the virus RNA.
okay.
When it prevents the multiplication of the RNA.
Uh-huh.
And this drug is available in India now.
Mhm.
It's available in select pharmacies in major cities. That is my understanding. Dr. Sudhakar can supplement it because he's from Bangalore. In Bangalore, I know it's available in a place called Cash Pharmacy, where all new drugs are available. And the course is for 5 days. A small correction, you should not take it unless RT-PCR is positive. It does have some side effects. So I would not recommend it that you should take the drug. PCR will be positive from day 2 onwards. So if 2-3 days you had symptoms, get an RT-PCR done, start Paxlovid. It will show dramatic improvement.
Thank you, Doctor.
Thank you. Good to see you. One small question, Prof. Ravi. This is probably everybody goes through this. You have maids working in your house. She comes home complaining of cold, fever. What do? Do you ask her to go and have a PCR test done? Or do you just tell her to be away, don't come into the family, and be away until her cold settles down?
The latter is the correct practical way of dealing with the situation. People who are symptomatic should refrain themselves from coming in contact with others. And those who are symptomatic certainly should wear a mask. If you look at the dynamics of transmission, if everybody wears a mask, the probability of transmission is very, very low. If you wear a mask, you can protect yourself to the tune of 90%. But the biggest advantage, if a symptomatic person wears a mask, you cut down transmission a great deal. In fact, I had published a Lancet paper on this simple common sense fact. It went for 7 revisions. Using the lockdown data and contact tracing and clinical data that is available, we showed that a symptomatic person transmits infection to 14 people on an average. This is data of about more than 1,500 COVID positive subjects. Whereas an asymptomatic person is able to transmit only to 2 or 3. Both transmit. Lancet went on, saying that, no, you are giving a wrong message. I said, I'm not giving a wrong message. Everybody transmits. But a symptomatic person, when he sneezes or coughs, I mean, it's common sense, you will release millions of viral particles. But they asked me to do so much of data mining and analysis. I'm very happy I did, because I learned a lot of statistics. And finally, we were able to prove that symptomatic people are the super spreaders compared to asymptomatic people. So my response to your question is, the most practical way of dealing with it is, if somebody has cold cough, they should refrain from mixing with others. And if they have to wear a mask. Whether COVID is there, not there, wearing mask gives so many other advantages, including for flu and dust allergies and so on and so forth. Agreed that it is not a comfortable thing to do. But when situations warrant, I think it has to be adopted.
Thank you.
I'm sorry, I sound very dogmatic in certain things, but
No, it's been very interesting. And
Hi, Badri, one addition would be, I am in Bangalore, as you know,
yes.
and now I see about 10% of the population in Bangalore wear masks, number
Correct.
one. Number two, me and my wife wear masks when I go to my daughter's house, which is opposite to mine. My daughter never wears. She lectures in college, school, and all that. She says no, she's immunized. But me and my wife, we wear it. When we step out, we wear it. And to differ from Professor Ravi, it is not a discomfort. It's like wearing socks.
Yeah.
No, when you wear for such a long time, some of my surgeons friends, they work for about 10 hours, 12 hours cardiothoracic.
Correct.
So you don't feel you are wearing it.
No,
So, I think when somebody, like you said about a maid coming in and so on.
Yeah.
So when a maid or anybody cook comes into our house, we both, my wife and me, go rush and put on a 95 mask. So you can all do that.
As I mentioned in my when I first introduced, I go out with a mask. Whether I'm in England or I'm in Chennai, I'm out with a mask all the time. And the only time I take the mask out is when I'm in a restaurant and just about to eat. That's the only time. So I'm not. I've got so used to it. I don't mind wearing the mask.
Good.
Professor Ravi, one
Yes, sir.
small question.
Yes, sir.
That RT-PCR, see, once COVID is there, it is positive. But does it become negative completely, or it doesn't become negative at all?
It does become negative, but symptomatically, when you improve, RT-PCR will not become negative. It takes longer because the virus lingers around and the dead virus also is picked up in RT-PCR. So RT-PCR normally by 10 to 12 days will become negative, although symptomatically 4 to 5 days. So over the COVID pandemic, we started getting revisions in isolation guidelines. Remember, 3 years back, it was 14 days isolation, then it came to 10 days. When it came to Omicron, the people said 5 days isolation is enough. And then now people say as soon as asymptomatic, your symptoms have gone, you don't transmit the virus. Okay, but RT-PCR will be positive for up to 10 to 12 days. In some people, up to 40 days. That's a very, very small percentage.
Thank you, Professor. Very good. Very kind of you. Nice reply.
I think it's been a fascinating evening talking to Professor. We all enjoyed this talk. I'm sure.
Very, very nice. This time, Badri, the answers, the questions were very, very pertinent, and probably because less of people have interacted, we got the excellent timing. We had enough of time to question and answer.
Yeah.
Thank you very much, Professor.
I must thank Dr. Badri for that, because he warned me that it should be interactive. So I reduced my presentation to as less as possible and had more time for it.
It's amazing. It's excellent. And thank you very much.
Thank you. Very nice of you.
Thank you. It's always a pleasure to connect with seniors.
Thank you. Thank you, sir.
Dr.
Dr. Sudhakar, would you like to?
Yeah. In fact, everybody's made my job much less. Thank you, Professor Ravi, for a lucid explanation of the coronavirus and also the way forward. And I'm looking forward to the day when we have a vaccination protocol for the COVID vaccine, which we will all take, as we do for the influenza vaccines every year. Maybe that day is not too far off. Thank you very much for your lucid talk. Thank you.
Thank you.